Namaskar, I'm Ashok Vyas. We are talking about health today. Health is an integral part of the way we determine quality of life. And someone who is expert in the field of brain tumor authority actually. Dr. Sumul Rao is board certified neurologist. Not only he is authority on brain tumor, he is also founding director of David S. Jucci, I might be pronouncing it incorrectly, but David S. Jucci Brain Tumor Center, and he is also past president of AAPI, and he is treasurer of AAPI as well as treasurer for Medical Society of New Jersey. There is so much wealth of knowledge with him, which he is generously going to share with us in today's show. First of all, Dr. Sumul Raval, welcome.
Namaste.
Namaste. Doctor, we are listening about ethnicity also playing its role in the way people become prone to stroke. Is that right?
That is so right. So before we start, I want to thank you and Padma Shri Sudhir Parikh for this interesting talk today. Stroke is one of the most common disabling disease in our country, and ethnicity plays a very serious role in incident of a stroke. So it's very, very important to understand that.
So, Doctor, in a layman's language, when you want someone to understand what is stroke, what are the symptoms and how is there any way that you can have some ideas what is happening in stroke?
Right, so it's very critically important to understand the symptoms of a stroke. So any sudden onset of brain dysfunction is more likely to be stroke than not. At the same time, there are so many other brain disorder can also cause similar symptoms. So it is very important to understand the difference between stroke and some other causes. But if somebody is having sudden onset of any neurological symptom that lasts more than a few minutes, you want to consider that as possibly stroke and want to get urgent help.
Again, since the body is one and most of our organs have some interrelationship, so sometimes you don't feel any pain in the heart side, but there is something else happening, and that later on is kind of leading to stroke. Does that happen?
There are some causes of a stroke that are related to the heart as well, but a lot of different. So let's start with talking about some common symptoms of a stroke.
Absolutely.
So basically, symptoms occur depending on the location where you're having a stroke in your brain. So it's common symptoms people experience is sudden onset of numbness on one side of the body or other side, sudden onset of weakness on one side or other side, sudden onset of difficulty with the speech, sudden onset of severe dizziness, sudden onset of difficulties with walking or balance issues. So those are the common symptoms people experience when they have some sort of neurological events, for example, stroke. And based on that, we decide what should be done next.
Yeah. So forgive my ignorance, and from layman's point of view, when we hear the term heart attack and when you hear the term stroke, are they synonymous? They're different.
No, they're different. But similarly, when people are calling a heart attack, we're also calling a brain stroke as a brain attack, because time is a brain. As important as for heart attack, the time is essence. Same thing, time is extremely critically important when people suffering from a stroke. So we call it a brain attack. So time is a brain. I said it many, many times. We must identify and treat aggressively so that people who come to the hospital within the first 3 hours of having stroke symptoms, less likely they will be disabled after the 3 months. So it is very, very important to get initial treatment rapidly.
Now, I repeat my question, how to have some idea that what is happening to me is a stroke, or people around someone who is experiencing stroke, is there anything that they can sort of see, not being doctors, but may have some idea that probably this is stroke?
So that's a very important question to understand, because lots of time the most limitation occurs when people go to bed normal and then wake up with some sort of neurological symptoms, what we call wake up stroke. And those are the most common reason people don't get aggressive interventions, because people wake up. So we have no way to know when symptoms started. When somebody is wide awake talking to somebody and sudden symptom occurs, you have precise onset of symptoms, and then those patients we can get exact onset, so we decide the treatment differently. So when somebody wake up with a stroke, then it's very difficult to understand exact timing of the stroke.
Now, looking at stroke and the way one would function in terms of the time gap, let me rephrase my question. There must be different types of strokes actually.
Right. So that is also very important to understand. So broadly, we divide stroke into hemorrhagic stroke and an ischemic stroke. In a hemorrhagic stroke, we have what we call ICH, intraparenchymal bleed. The hemorrhage occurs inside the brain matter. That is called ICH, intracranial bleed. The second one is what we call subarachnoid bleed, which occurs, the blood occurs in CSF, cerebrospinal fluid space, occurs very commonly with people who has ruptured brain aneurysm. So this is what we call hemorrhagic events. The other part of the stroke, what we call ischemic stroke, where either the stroke occurs because there is a thrombosis, where the atherosclerotic things occurs in a blood vessel and a blood vessel get occluded, or people get what we call embolic stroke, where the clot arises somewhere else in our heart or blood arteries, that goes to the part of the brain and cause neurological complication. And the third reason, what we call hypoperfusion, for whatever reason, if the perfusion goes down in a brain, you get certain type of stroke events. So these are the two major kind, hemorrhagic and ischemic strokes.
And Dr. Taking advantage of your presence, and many of us don't understand how our brain functions. Now, in order to have clarity about stroke, is it possible that briefly you sort of describe the way brain functions? And my important concern is why stroke happens.
So ischemic stroke occurs most likely because of certain risk factors. And the most common risk factor is hypertension. High blood pressure is one of the most common risk factor. High cholesterol is second most common risk factor. Smoking is another very high risk factor. Obesity is another risk factor. Diabetes is another risk factor. So when people have those kind of multiple risk factor in a one individual, your risk of having strokes are very, very high.
No, hypertension is the term that I would associate with having stress or worrying too much. Is that correct way to kind of look at?
I think stress and worries too much may make your blood pressure a little bit worse. Lots of people have underlying high blood pressure as a disease. So when people have hypertension, your chances of having stroke goes higher if you are in a different kinds of reasons where that makes your blood pressure goes high.
In your experience of serving patients for almost 4 decades, I believe, you must have come across thousands of patients. Is there any average age which you feel is prone to strokes? Let's say if I say if you are young, you will not have stroke. If you are below 16, you won't have stroke. Something like that, or? So
that is also very interesting. Incidence of strokes are getting higher in the younger individuals now than before. We generally see people 65 and above in a hospital with a variety of different stroke symptoms, and different kind of strokes. But younger people are now having increasing events with the strokes.
And so recovery process would be different based on what age group you are or not?
So I think the recovery depends on your initial arrival, what time you come to the hospital, what kind of interventions you received at the hospital. So treatment is, so when we have a stroke patient come to the emergency room, there are certain protocols that we have to follow. What we call stroke team, there's a stroke team in most hospitals. get activated when patient arrive. Even when 911 get called with stroke symptoms, the emergency team alert ER physician there's a stroke patient coming, and ER physician is alert to whatever needs to be done for those stroke patients. So as soon as stroke patient comes to the emergency room, there is a certain protocol that we follow, what we call code stroke. So once patient comes to the emergency room, we want to make sure that person is candidate to get aggressive interventions. In that regard, initially we have to do just ABC, like airway protection, breathing, and all those common things. We check, we do rapid history taking, we do rapid physical examination, we do rapid blood work, what we would call CBC, chemistry, routine prothrombin time, and we do CAT scan of the brain and or possible MRI, depends on what is available that we can get right away.
So, Doctor, this question may or may not be relevant. Many times we have seen that service of medical assistance is quite prompt. If you call 911, you get ambulance. But let's say if you are at a place where you don't have that quick availability of ambulance, and you suspect that there might be the case of stroke, then if you carry him in the back seat of car, will that affect him adversely, or it's all right if you are careful?
So I mean, if you get that person to the hospital whatever way fastest possible, that matters the most.
I see.
When we say 911, it's the best and fastest way to get to the patient to the hospital. It is not easy to get somebody with some symptoms. If somebody is paralyzed on one side, it's not easy to carry that person, depending on how heavy the person is, to the car or back of the car seat. So I think I would always suggest that if it is possible, you always call 911 and bring the person to the nearest emergency room.
And now, when someone is brought to emergency room in a hospital, they may or may not have any idea that it is actually stroke. And probably there is a way whereby the team identifies that this is a case of stroke, and then, so once they come to you, like if you are treating them, what are the first steps that are taken?
Right, so that is the most important part of the stroke management, to take whatever those initial steps in a management of the stroke. So as soon as I mentioned earlier, when patient comes to the hospital, we activate the stroke team. So there is a 24/7 neurologist on a call for each and every hospital. Nowadays, in almost every hospital, what we call primary stroke center and a secondary stroke center. So primary stroke center is able to provide whatever needs to be done from treatment as a basic treatment for the stroke. And when you have a secondary stroke center, where we can be able to provide with more advanced stroke treatment. So as soon as patient come to the emergency room, we do the routine workup, we do the CAT scan. We want to make sure that person is eligible to get what we call TPA, or now what we call different kinds of blood thinner. So I mean clot buster injection. So I call clot buster injection for layman's term, because I always tell people that if you are to come to the hospital, we used to give it within the first 3 hours, now 4.5 hours. If you come to the hospital within that time, we will give you that clot buster injection that will dissolve your clot much faster, and you will be less disabled for a lot less time.
So these things are very important, how the management of stroke takes place. And if I look at the situation of stroke, from the point of view of gender, is it some data suggesting that for men they are more likely to have stroke as compared to women, or what do you think is the percentage, and recovery wise also does it matter?
I think it's more important man, female versus race is critically more important.
I see.
Because African Americans are almost double the risk to have a stroke than white Americans. And also African Americans are more likely to die from a stroke than white Americans. For last decade, almost incidents are slightly decreased in a way in a ethnic population standpoint, except the Spanish population. Spanish population has increased incidence of stroke in last decade.
In order to stay healthy, the way you lead your life, whatever your lifestyle is, that plays its role, as well as your genes or DNA, whatever. So when you share this comparison race-wise, is it because of the lifestyle or it is something inborn?
I think it's multifactorial. More likely to be how we live, how we are. It's different. Race are slightly higher incidence of having high blood pressure, diabetes and cholesterol. We also have different categories of care as well. So some populations get little lower level of care than other. We have access to different access to the care as well. So I think there are a lot of combination, and of course genetic formation is the most important thing. For example, Indians are much higher risk to have cardiovascular event than now what we call as where people the risk factor, like high, as I mentioned, high blood pressure, diabetes, cholesterol. Indian is a risk factor to have a cardiovascular event. So more Indians are having cardiovascular event than non.
Now that we are talking about the way stroke and people from Indian origin have some sort of relationship, let's look at the way it is treated in India as compared to the way it is treated here. And being treasurer of AAPI as well as having served through several organizations, I'm sure you have first-hand idea as to the way facilities in India are addressing patient with stroke. Is it parallel or there are some different protocols?
The way we treat here, absolutely, I mean, has lots of significant improvement back home in India as well. But the treatment here, it's definitely a lot more advanced. And I'm very, very glad to say that when stroke program started in New Jersey, I was a chief resident in Department of Neurology at UMD-NJ. So we were carrying the first what we call TPAB for those days. So patient come to the emergency room, we are already waiting for the patient at the emergency room. So we have this is going on for last almost three decades that I'm taking care of patients with stroke. So there's definitely significant advances in management of the stroke. So in addition to giving people what we call intravascular thrombolysis, what we call TPA or TNK nowadays, where we give the intravenous injection within the first 4.5 hours. What also now we are doing is neurosurgical interventions, so what we call clot retrieval. So depending on where in the brain you have a clot, we call our interventional neurosurgeon friend, who then going to take the patient to the operating room no matter what time of the day or night. They will have a device that goes into the brain blood vessel where there is a clot, and they retrieve the clot back. And I had seen people moving their hands right on the operating table after that procedure.
Wow, wow. I believe you have also been in the forefront in terms of some very difficult cases that you managed to solve by maybe different kind of permutation, combination, or would you kindly share the case that was very life-threatening and you devised a different way to approach it?
Right. So I think that is, so the treatment depends, the patient's life prognosis quality depends on early and rapid interventions. So I just mentioned a patient received the intravenous thrombolysis had no improvement. Surgeon goes in and take out the device. I had seen, and also depends on the location of the clot in your brain. So sometime people will improve with lots of physical therapy versus depending on the location. For example, posterior circulation, what we call. If somebody is having a posterior circulation stroke where part of your brainstem get infarcted, you want to get a very aggressive interventions no matter what, because that person's quality of life is going to be very seriously disabled. So those patients, or what we call left MCA stroke, where the language function is going to be affected, person is not able to comprehend, patient is not able to move on one side of the body, we ask our interventional neurosurgeon to stay very aggressive for those kind of patients. And we had seen people with those aggressive interventions, very serious improvement, and patient goes home walking, and that makes you feel so good.
Now, looking at coma stage that some people get to, that has something to do with stroke?
Well, generally speaking, stroke can cause very rarely to the comatose situation unless somebody is having a massive bilateral bihemispheric stroke, or somebody is having a massive brainstem stroke that can lead to your alertness goes down. Normally speaking, less likely people goes in a comatose situation, but they are neurologically so disabled that they may not be able to function much. So kind of interchangeably use the word in layman's language.
So now as we move towards the concluding part of our conversation, in terms of the long-term management of stroke, do they need to stay in some nursing home, or after some stage in the treatment, they can go home and manage their...
Right, so that is the most important phase of recovery after having a hyperacute and acute treatment stage. Just to mention earlier regarding the incident, we have about 800,000 patients in our country get stroke every year, and that cost around $53 billion cost to the healthcare. That includes all the initial stage and long term and loss of work as well. So once we are ready to send that person for a long term care, I always tell hospital social workers and whoever help us send person to the appropriate discharge, that I want this person to go to the acute care rehab hospital, where person gets maximum amount of physical therapy and occupational therapy, speech, depending on the location of the stroke, what therapy they need the most, that will help them get better fastest. So first 2 months, people recover, their motor strength recover the fastest. So you want to do that therapy as much possible during those time. So the placement to the acute rehab care is the most important.
So I'm talking to Dr. Sumul Raval. He is, of course, the authority on brain tumor. As we move towards the concluding part of our conversation, one most satisfying moment in your practice that you can share?
I think there are so many. People hear me saying that I have many cases in my my office, and my practice is like a best-selling story in New York Times. One day I will write those cases and book about it. I already have a topic in my mind, what I'm going to call that book, but there are so many different cases. But I had one patient who came to hospital. Only 16-year-old young girl comes to the hospital with sudden onset of right-sided weakness and not able to speak. And when 16-year-old patient come to the hospital, last thing you would think is having a stroke. I was, as a stroke team on-call neurologist, I was asked to see her. I rushed into the hospital, and while I was walking in, I asked the ER physician to get CT perfusion test, which is tell me what kind of, if there's any stroke is happening in the brain. As soon as I walked in, I looked at the CT perfusion, and I saw there is a perfusion mismatch in her CAT scan. And I told the emergency room physician that this young girl is having an acute stroke and we need to give her thrombolytic therapies. We gave her intravenous thrombolytic therapy, and I am so happy that that young girl now is almost 20 some year old and walked to my office and talked to me, and she and her family always say that, doctor, I don't know how to thank you for what you did. And I feel that I don't know why I thought about stroke for that young girl that day, and that story I can never forget.
That's really beautiful, incredible. And while you receive thanks from your patients, here is someone who's talking to you also, thanking you for joining us and enlightening us on how to be more vigilant about not getting into the state of stroke, and if there is someone there, how we can help them in the best possible manner. I wish you all the best for your continued commitment to serve the society as a physician as well as treasurer of AAPI and Medical Society of New Jersey. Thank you very much for joining us.
Thank you for having me, and I want to thank our sponsor for this event as well, Mobility Clinic.
Wonderful. So thanking Mobility Clinic along with Dr. Sumul Raval, and thanking all of you with lots and lots of good wishes. This is Ashok Vyas. Namaste.